All right, let's get right into it. A GI bleed. It's probably one of the most common and, let's be real, one of the most stressful calls you're going to get as a trainee. So what we're going to do here is build a really clear, repeatable framework so you can handle these cases with confidence, from that first page all the way to a safe discharge.
I want you to picture this, because you will live this. It's 3 in the morning. Your pager screams, GI bleed. Your heart immediately starts pounding. What do? Order labs? Call GI for a scope? Honestly, the number of options can feel pretty overwhelming. But here's the secret. The key isn't knowing the final answer right away. It's about having a system. So let's build that system together right now.
So here's our game plan. We're going to start with the absolute #1 priority, resuscitation. Then we'll get into the 2 big types of upper GI bleeds, ulcers and varices, because you manage them very, very differently. After that, we'll head downstream to lower GI bleeds, and then we'll wrap up with maybe the most important part, how to stop this from happening all over again.
Okay, step 1 of the system. Before you even think about where the bleed is coming from, you have to make sure your patient is stable. This is the cardinal rule, the one thing you can't forget. Resuscitate first. Everything else can wait. What you do in these first few minutes can literally be the difference between life and death.
So what does resuscitation actually look like? Well, it's your ABCs, really. First, you assess their hemodynamic status. Are they tachycardic, hypotensive? Get those vitals right away. Second, you secure access. And I don't mean just any access. You need 2 large-bore IVs. We're talking 18 gauge or bigger. Think of these as your lifelines for fluids and blood. Then you start pouring in crystalloids like lactated ringers or normal saline. And finally, you have to figure out if they need blood. And when it comes to transfusing, the modern approach might actually surprise you.
Now this is really fascinating, because it kind of goes against your gut instinct. You'd think more blood is always better, right? But the evidence just doesn't back that up. This landmark trial showed that a restrictive transfusion strategy, which means we only transfuse when hemoglobin drops below 7, is actually better than a liberal one. I mean, just look at these numbers. The restrictive group had almost half the mortality rate, way less rebleeding, and fewer adverse events. So the takeaway is super clear. Unless your patient is actively exsanguinating or has severe heart disease, you should aim for a hemoglobin target between 7 and 9. Do not overtransfuse.
Okay, so your patient is stabilized. Now we can put on our detective hats and start investigating. We're going to start with upper GI bleeds, and the most common cause by a long shot is peptic ulcer disease. This is your absolute bread and butter GI bleed.
This table right here is absolutely essential. You have to know this. The Forrest classification is how we talk about what we see during an endoscopy, and it tells us exactly what to do by predicting the rebleed risk. So you have to know the high-risk ones. Forrest 1A, that's an active arterial spurter, huge rebleed risk. 1B is oozing, and 2A, the non-bleeding visible vessel. This one's tricky. It looks quiet but has a 50% chance of rebleeding. Those 3, 1A, 1B, and 2A, are the ones that absolutely need endoscopic therapy. The lower risk stuff, like a flat spot or a clean base, we can leave those alone.
So for those high-risk ulcers we were just talking about, what's the right therapy? Well, the evidence couldn't be clearer. Dual therapy is the standard of care. Just injecting epinephrine is not enough. The risk of rebleeding is way too high. You have to combine it with a second tool, like a mechanical clip or a thermal probe. This combo is way more effective at stopping the bleed for good and preventing it from coming back.
Okay, the work is not over after the scope comes out. To stop another bleed, you have to start high-dose IV proton pump inhibitors, either as a drip or twice-a-day dosing. See, the stomach's acidic environment is really hostile to forming a stable clot, so we have to shut down that acid production. And just as important, you have to figure out why the ulcer happened in the first place. That means testing for H. pylori and, of course, treating it if it's there. This is such a critical piece of the puzzle. Now we're going to switch gears completely. Let's talk about a much more dangerous type of upper GI bleed, variceal hemorrhage. This is bleeding from these big dilated veins in the esophagus or stomach, usually in patients with cirrhosis. The mortality rate is way higher and the management is totally different.
And this chart, wow, this shows one of the biggest advances we've made in managing these patients. For those at the highest risk, we're talking Child-Pugh Class C or Class B with active bleeding, getting an early TIPS makes a massive difference. A TIPS is basically a shunt that lowers the pressure in those veins. And look at this. Getting that shunt placed within 72 hours boosts 1-year survival from 61% all the way up to 86%. That is absolutely a practice-changing finding.
So, managing a variceal bleed is like a cascade of steps. You immediately start vasoactive drugs like octreotide to lower the pressure. Critically, you also give prophylactic antibiotics because infection is a huge trigger for bleeding in these folks. Then, it's off to endoscopy for banding. If that doesn't work, or the bleeding is just out of control, you've got bridge therapies like balloon tamponade, which hopefully gets them to the definitive treatment, a TIPS.
Okay, here's a device you need to know about, even though you really hope you never have to use it. This is the Sengstaken-Blakemore tube. Think of it as a life-saving bridge. When you have a massive, uncontrollable variceal bleed and you can't get to a definitive therapy right away, this thing can save a life. You inflate these balloons in the stomach and esophagus, and that direct pressure can temporarily stop the hemorrhage until a patient can get to interventional radiology for a TIPS.
All right, we've covered the upper tract. Now let's head downstream to lower GI bleeding. Now these are often less hemodynamically dramatic than a big upper GI bleed. The main challenge here is often just figuring out where in that long, winding colon the bleeding is actually coming from.
So, what's causing it? Well, far and away, the most common culprit is diverticulosis. That accounts for about 40% of cases. These are usually painless, pretty brisk bleeds from those little outpouchings in the colon wall. Other common causes are ischemic colitis, angiodysplasia, and bleeding after a polypectomy. Just having this list in your head is super helpful when you start your workup. Now, your approach here completely hinges on one single question. Is the patient stable or unstable? This creates a huge fork in the road. If your patient is unstable with a brisk lower GI bleed, forget the bowel prep. The first step is a CT angiogram. It can find the spot of active bleeding really fast. If it's positive, the patient goes straight to IR for embolization. But if the patient is stable, the best move is a rapid bowel prep and then a colonoscopy, which lets you both diagnose and potentially treat at the same time. So, we've stopped the bleed. Great. But our job is not done. The final, and you could argue most important phase of management is thinking about how to prevent this from ever happening again. This is where we shift from putting out the fire to fireproofing the building.
And this prevention has to be tailored to the cause. For ulcers, it's all about getting rid of H. pylori and long-term acid suppression. For varices, it's lowering that portal pressure with beta blockers or getting rid of the varices with banding. For diverticular bleeding, the single most important thing you can do is stop NSAIDs. And for trickier things like angiodysplasia, there are other specialized therapies. The bottom line is, every patient needs a specific plan.
So we'll end on this question. Stopping the acute hemorrhage? That's a huge win, but it's really only half the battle. True success is making sure your patient walks out with a clear, evidence-based plan to make sure they don't come back with the same problem. And that's really the difference between reactive and proactive medicine, and it's the whole point of the system we just walked through.